Hi, everyone, and welcome to another Global PAD Impact Awards presentation. Today, I'm honored to announce our 2025 Global Luminary of the Year, Dr. Ankur Thapar. Dr. Thapar has distinguished himself through groundbreaking research in peripheral artery disease, that poor circulation in mainly the legs due to arterial blockages. And he's done this while maintaining an unwavering commitment to PAD care. His work, bridging rigorous clinical studies with practical vascular interventions, has transformed how we approach PAD management, I think, globally. At a time when peripheral artery disease affects millions worldwide, Dr. Thapar's evidence based innovations and collaborative approach to vascular surgery have provided new pathways for treatment that prioritize limb preservation and quality of life. His publications have been cited extensively in clinical guidelines, and his surgical techniques have been adopted by vascular specialists, I think, across continents. More importantly, his methods have directly improved outcomes for countless patients facing limb threatening conditions. So please join me in welcoming the Global PAD Association's Global Luminary of the Year for 2025, Dr. Ankur Thapar. Thank you so much for joining us, Doctor.
Oh, it's an absolute pleasure, Kim, and I can't thank the community enough for the award. It really does mean a heck of a lot to us.
Well, you're working so hard. Your research has significantly influenced contemporary PAD treatment protocols. So, could you share which of your studies you think had the most meaningful impact on patient outcomes and how you identified that particular area of need?
That's a great question. What I'd probably say, to date, Reset 2. So, Reset 2 was a walking randomized control trial. And we looked at using an app similar to what you guys use in the States. And we looked at the effect of that versus remote physiotherapy with the app. And what we found, quite surprisingly, was that just with the app, the motivation was really, really good, really strong. And the patients walked pretty much the same kind of distance at 6 months benefit than they did with the physio. So for us, that was like the complete opposite of what we thought. But it opened up a big treatment population who couldn't get to the center for physio, who couldn't access MS Teams or FaceTime or WhatsApp video to do the video calls with the physios. And actually, that's become the mainstay of our clinic. And that was a complete surprise to us, the opposite result of what we thought. But yeah, so I'd say to date, probably Reset.
So was there coaching or anything that went along with it, or it was just an
Yeah.
accountability app that basically said
Um,
press this button and walk?
Yeah, so in we had two arms. We had the treatment arm where the physios were doing coaching. They looked at your house, they saw your garden, they gave you a personalized exercise plan, and they called you every couple of weeks for 3 months, and then you were asked to maintain your treatment for 3 months. So the guys in that group walked about 350 meters extra at 6 months, which is a good gain. That's a meaningful gain. You can walk around the shops, you get down the road, get to the bus stop. Um, and then to our surprise, the guys who just got the app and who we checked in with at 3 months, checked in with at 6 months, but didn't really do much more apart from look at their logs to see that they were doing it. They got 300 meters, which is pretty good, and it was free. So for us, that was a big surprise for us. So the physio added about 50 meters in our place, but it was a good message for everyone that even just using today's straightforward technology that most of us have
Yeah.
on our phone, and we had options for people that didn't have phones. We just said buy a stopwatch and a diary, write down your times, do a 6-minute walk test every month. Even those guys got really good benefit, and you can adapt it to the technology level of people. So yeah, really similar results in both arms. So it was a win for patients as well, I think.
That's actually pretty good news for us, with our app because it's just a basic app that measures claudication time, time to rest, and your walking distance over time and how it improves. And then on top of that, we couple it with community and motivation and weekly seminars that they're welcome to attend, as well to ask questions of doctors of physiotherapy and other experts about their experience. But that is really good news. I love that. They just need a little accountability and a little push, right?
Yeah, I mean, some people have called this the carrot and the stick trial, and the stick won. But I don't know. It's good news, isn't it? It's good news. The least complicated way of achieving a safe result and putting people in control of their own disease. I mean, that's what you need, right?
Yeah, I mean, we've had patients tell us if only the doctor would have at least told me to walk through the pain, that would have made a difference for me. Not just say go home and walk, 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 but literally hold me accountable, tell me how to walk effectively, encourage me to walk through that pain. And I would have done it if I knew that I would have kept my leg today.
Yeah, and I think that's a good point. And there are two other really good points. So that 6 month period we looked at, that's not just about walking. Actually, during that period, the guys are giving up smoking. They're starting to take their medication, find out if their medication doses need altering. We alter them. We get them fully medicated, off cigarettes, and they start losing weight. So they walk further just because they lose weight. And so when it comes to 6 months, this probably saves 70% of people progressing towards a revascularization. That's what we found. And it tends to be the young guys who really don't walk far, who work. They tend to need revascularization early, whereas most of the rest of the guys, and I'm saying 70% in our trial, they didn't need revascularization. So economically for us, it was a great win. It was a great win. And if you're one of those, 3 out of 10 people that needed revascularization, you're in as good a shape as we can get you to have an operation. So it's a prehabilitation for the guys that need a surgery as well.
Yeah, you got to get people in the habit of walking and moving before you have the procedure, if at all possible. If it's someone that doesn't have a wound, I mean, when you have a few days before, I mean, get them to move, get them to do something because if they're not walking now, they're not moving now, they're not going to move afterwards.
Yeah, 100% agree. 100%
So
agree.
we've previously discussed, your research work, but I'm curious about the connection between your clinical observations and research directions. How has your direct patient experience shaped your investigative priorities, particularly for limb salvage techniques?
Okay, well that's a great question. So I'm going to give you I'm going to Kenan, I'm going to talk a little bit about the work you're doing, and I'll bring Kenan in on this actually. So Kenan is looking at patients we historically have ignored. And so these are guys who we have kind of exhausted all revascularization options on. And there's a new revascularization option every year, so that changes, that picture changes. But we've kind of said there's nothing else we can do for you. Go live your life. And if you look at the kind of life these guys lead, they're in pain, they've got wounds, and some of them are considering like palliative procedures, like palliative amputation, palliative revascularization, and some of them aren't. They actually just want good symptom control and to have as good as life as they can. And we've just put a blanket on those guys. We've put them in a corner and we have taken the blanket off and we're asking them about what life is like. So Kenan, I'm going to bring you in to just tell us a little bit about the literature in these patients that we haven't yet succeeded in treating and what we can do for them.
Yes, absolutely. Thanks, Mr. Thapar. So these subset of patients, they're very underrepresented, I think, in the literature, with very little studies investigating them, and even a smaller number of studies in investigating their opinions and how to manage them. So there are a couple of studies which I've seen. There's a couple of observational studies. There's no randomized studies. There's a systematic review that's been done about a couple of, which included a couple of studies, but only 2 studies of them included patient observations and patients' recommendation. So that's how underutilized these patients' experiences are in terms of the literature and how can they affect the treatment for themselves and for the future patients. So that's another major important underrepresented cohort of patients that we need to look at. And if you look at the morbidity and mortality of peripheral artery disease, especially chronic life-threatening ischemia, it has a very high mortality rate and morbidity rate. Like the mortality rate is what? It's around 70% in after 5 years, which is basically more than coronary artery disease. So it has very, very strong impact. And these, not as Mr. Thapar said, not all patients can get treatment and revascularization. Some just need to be just left alone, have their peace. And these, I think, we need to do more for these patients.
I
So
agree.
what,
We just had a gentleman who, passed away, and it was miserable. And his daughter was giving us the play-by-play every day, and no one would help him. I mean, imagine sitting there and having your legs die off, starting off with your toes dying off one by one, and just further just progressing up the leg. I mean, tissue dying is incredibly painful. And even with the palliative care medications for pain control, they weren't even cutting it for this poor gentleman, and yet still no one would do anything.
so Kym, it's a condition which hasn't changed since the medieval ages, dying from gangrene or suffering
Mm.
with gangrene at home. And if you look at what breast cancer treatment was like 40 years ago, it was a taboo, it was disfiguring, it affected one gender more than the other. It was something people put under layers of clothing and ignored and suffered at home. And, they had really bad outcomes. Look at where breast cancer is today. It's not a taboo. It's something which is celebrated. It's something which is treatable. It's something with support in the community. It's something where the drug treatment is there to let you extend and have a good as life as anyone else. And I think we're going through that thought process in CLTI. We're a few years behind. And for us, as part of a regional PAD center, what we do is we look at the entire spectrum of patients. And, this spectrum of patients, there are quite a few people, I would say like 2 a month in our place that would go into this category. And historically, what's been our treatment plan? No further revascularization option. That's our entire treatment plan. What happens when they go home? Would they like to be at home? Can they cope at home? What happens when their pain gets really bad? Would we discuss a palliative amputation or angio for pain relief? Would we discuss a sympathectomy? Would we discuss something else? So that's like a totally new area of research that Kenan has kind of tripped on, and that we are actively looking to involve patients, families, and also ask clinicians, what are the barriers to you discussing with patients in clinic? Is it too difficult? Do you have enough time? How should we phrase this question? And what's important to the patients in this? Is it being at home? Is it being free of pain? Is it not having unnecessary procedures? Or are there procedures which are really beneficial? We don't know anything about this area. There is no literature.
But what if it could be different for different people? For example, I had one patient that was recently, they were discussing he's end stage renal disease, and he wanted to be kept on dialysis longer. And it was most important that he could have just another day and another day and another day and as many other days as he could with his grandchildren. And my dad just had one of his military friends, similar situation. And he said, I honestly, if I'm going to die anyway, I just want to go. Just take me off the dialysis, put me on hospice, palliative care, and just let me just go. And so for different people, the different priorities. And I think that what you're trying to do, though, is um, uncover what the options are. What are the different scenarios that are out there? And then be able to create a productive discussion that a physician can have with their patient, understanding all of the different scenarios, correct?
Correct. And do things like have a model video of how you could introduce this if you needed to introduce this as a clinician. It could be a senior doctor, it could be a senior nurse. But to introduce that, if you felt that this was actually an appropriate thing that people might want to ask, but might be afraid of asking about. And for us, we don't always understand what's in that box. Like if you ask me, even I'm not really sure what's in that box. I need to go and understand it, and understand all the different options and see it from another point of view. And so we've brought in experts from palliative care. We've brought in experts from social science to try and understand this really difficult area. And as you say, it's just as individualized as all our other treatment.
Yeah.
And there are surgical options and there are non-surgical options, just like all our other treatment. And what is it? It's an extension of our care for our frail patients with advanced vascular disease. It's our, it's still a portion of patients where we have to improve our treatment methodology for. So that's something completely different we're looking at next year.
Yeah, I think that warms my heart. Just being on the front lines with patients when they're not in your office, when they are at home, when they are on social media, and they are suffering, or the family is suffering right alongside the patient. It's nice to know that you are listening, but this is something that going forward, that other people don't have to go through what they're going through. But the key will be, it is a long process, right? From the point that you're studying this, clear through, and then making sure that the information trickles down to every single physician that has a touch point with these patients to understand what are the different options that are available, at all of these levels. You were giving me the example before we started this conversation on the deep vein arterialization, I believe, where they hijack a vein in the calf and reroute blood flow into the foot, using the vein. And here a lot of patients, we always say it's going to get worse, it's going to get angry, you're going to be, you gotta be a pretty tough cookie to get through those. But they don't have options as much here, let's say in the States, for managing that pain. But over there where you are, at least at your hospital, there is an option. You have found a way to handle the pain.
Yeah,
But we
so
got to democratize access to all of this. That's
yeah,
an issue.
absolutely right. And you got to share experience. So one of the things, one of the things we're trying to teach, we're trying to share with guys like Alfie who are coming through, who are going to be flying solo in the not too distant future, is these kind of strange off-piste procedures that sometimes can be of benefit, and we really need to assess them. And so the last paper we have put out is our results of venous arterialization in our
Oh,
center. And I wouldn't say we've done huge amounts. I don't think anyone's done huge amounts, but we have learned that some people get a lot of pain after the procedure and they need adjunctive pain relief procedures. So injections into the nerves in the back to numb the nerves in the leg. And that can tide them through, the first month or so after the procedure where they can get a lot of foot pain. And
yeah.
I'm pleased to report we have the longest running venous arterialization in the literature. It's 3.5 years and she's still going.
That's incredible. We would love to interview her at some point. Send her my way. Would love to
Yeah.
talk to her because that she's become a good partner in her care. That she has to be, no smoking. She has to be eating better. She must be compliant with her medications because that's advanced stage, critical limb ischemia. I mean, that's serious business. Well, it also speaks volumes to your technical skill too.
Well, every now and then, God gives you a bit of luck, and you know what? I'm quite happy to take it.
That's
So,
pretty incredible.
yeah,
Um,
so she's 40. She's the same age as me. I'm not going to give you the exact number, okay? But she's in her 40s, and she's a mum of three.
wow.
And she had a very transformational few years, where I think the realities of what she was doing, smoking around kids, etc., suddenly hit home. And
Mm,
the fact that she got another life, she really did get another life. Her wounds healed, her pain settled down, and she walks. I wouldn't say she walks huge distances, but she gets to the bus stop. She can get on a bus, go to the shops, come
yeah.
home. That's a big deal for her. And so I think part of the mission really is when we have these procedures is for guys like Alfie and Kenan coming through is to understand where the role of these procedures are, who to select out for them, who to what kind of numbers of success rates would you expect? What kind of other procedures might they need for pain relief afterwards? So that when they're in their own careers, they can talk to people effectively and give them the information.
And Alfie, you've come in at a really fun time as we're now discovering that PAD is less and less a top-down disease, big vessel disease, and more it's a bottoms-up disease. So I imagine that you being where you are, working with the best of the best and with the most advanced, you're excited to get out there. It's nice to have someone else that's getting out there with these skills that can address, for example, today we had a 28-year-old come to our group with bilateral disease all below the knee. And it's scary because you go online and you see if you doctor Google, you're going to be dead in 5 years if you have PAD, you're diagnosed. And that's no longer the case for most people, but for a 28-year-old seeing that is really scary.
Yeah, well, yeah, like you say, vascular disease is so scary and terrifying, and unfortunately, it doesn't seem to affect people very fairly. There seem to be some people who, maybe haven't smoked for particularly long or didn't smoke particularly heavily, and then they've been sort of cursed with horrible disease, especially if it's below the knee, and then it becomes an extra difficult treatment challenge. But as sort of Mr. Thapar said, the exciting thing that we've got going ahead is that we're thinking of different ways to treat disease and coming up with combinations of open and endovascular technology to try and treat everyone on a sort of individual basis. So I think that's the sort of best part, really, that there's no kind of one size fits all treatment strategy. We can come up with like an individualized plan and use some of our different skill sets and combine that with our open surgical skills, our endovascular techniques, and find a way of treating patients in a way that will benefit them, but also make sure that they don't take too much of a hit from a massive open operation, or can get through the anesthetic, that sort of stuff.
You bring up a good point. I mean, evidence in medicine requires rigorous data, but yet PAD presents, very unique challenges for standardized research. I mean, especially with so many people presenting so differently. What innovative approaches have you developed to overcome these challenges while maintaining the scientific validity, with everything that you're working on?
Well, I mean, at the moment, we've been building a sort of shockwave registry. So that's the intravascular lithotripsy technology that's taken off in the last couple of years. So that utilizes sound waves to sort of vaporize calcium within the vessel wall, and therefore make the vessels more compliant. And so we've been using that technology over the last year at Mid and South Essex, and we've been keeping a robust registry database to ensure that we're not just using technologies that sort of with blasé, but actually maintaining sort of rigorous scientific data. And I think that's the important part, like analyzing what's happened, looking at the patient case series, and then ensuring that you're actually doing good. And I think that's what Mr. Thapar is so good at, recognizing the new technologies that offer benefit, and then actually making sure to hold those to account as well.
Alfie's actually responsible for looking at the implantable antibiotics with our other fellow Nishita. So I don't know, Alfie, if you want to give us a quick one-liner of where you are with that at the moment.
Oh, that's interesting for the patients that have the osteomyelitis.
Yeah, exactly. So that's also what we've been looking at. So thankfully, because one of our orthopedic surgeons has been using this technology previously for treating osteomyelitis in orthopedic patients, we've been able to transfer that into the peripheral arterial disease patients, and particularly diabetic foot, but just osteomyelitic disease in patients with tibial and pedal disease. And what we've found is that actually, rather than the standard traditional treatment of 6 weeks of IV antibiotics, this new implantable antibiotic bone support basically enables you to treat that with just short courses of oral antibiotics with much less systemic side effects. And so we've been keeping track of this patient cohort over the last year just to, still make sure that it's safe and effective. And we've had really promising results so far.
It's so nice when you have something that's already out there and cleared and it's in use. It's so much easier to be able to adapt it for another use within your hospital system, I would imagine, versus something completely new from outside the organization and bringing it in.
Yeah, I
So
mean, I
that
think that seems to be the thing I've definitely seen from the diabetic foot service that they have. You know, Mr. Thapar and the orthopedic consultant that we've mentioned have managed to build together. It's a very collaborative teamwork where they're able to exchange ideas and, you know, have made definite patient benefit from that collaboration.
Yeah.
So I would say, you know, the next step for us really is those big open wounds that are left after, you know, we've revascularized, we've treated the bone, and
Yeah.
we just need to cover. We need to cover wounds which are vascularity is maybe not good enough for a flap. And so we've actually brought in one of our plastic surgeon colleagues who's an expert at using like an absorbable dermal scaffold. We call this BTM. And so we've started using this for those kind of difficult wounds. And I would say in about 2/3 of patients, we get a good take and we get a nice result. And so one of the projects for next year really is bringing that part of the team in a big way and looking in a big volume of patients to see where we are with that technology now that we've got over our learning curve. And that's something straightforward that can make a massive difference to patients. So one of the cases that when I picked up this case, I wanted to hit myself. I wanted to hide in a dark room. I had a fantastic young lady with an occluded aorta, multiple previous stents, and
Mm.
previous acts by FEM, so bypass from the arm coming down to both groins, big ulcers on the legs. And the referral said, please, could you redo this lady's axillary bifemoral bypass? And I thought, wow, this is going to be a tough, tough day at the office. Um, that lady is being discharged tomorrow, and she
Wow.
needed so much input from my colleagues. So she needed another colleague to help me do the redo bypass. And once we did that, we cleaned up her wounds while she was asleep, took her back to theatre, and then applied all the artificial skin to all of her wounds, both shins. And then we found her heel, unfortunately, had developed a pressure sore from being in bed. So last week, I took her back to theatre. We drilled the heel, we laced it with antibiotics, and we covered it with artificial skin. And do you know what? Even thinking about that 5 years ago, I don't even know what we would have done. We probably would have put a suction dressing on and gave her an intravenous line and gone home with antibiotics for 6 weeks, pretty much knowing that she'd come back for an amputation. You know, delaying the inevitable. So the speed of the new technology coming is really mind-blowing. And for us, it's using it, but auditing it and publishing results so people know what works, what doesn't work. And
Yeah.
I'm quite happy to publish bad results. So it's important for us to know some of the stuff which works and some of the stuff which doesn't work. So some of the other projects that guys are doing is looking at through knee amputations. So a new amputation for people who want to walk, who can't have a below the knee amputation, or it's failed. And so
Mhm.
for us, we looked at we've probably done the most in the United Kingdom. And it's something that we'll offer to people who we think are going to walk. And we looked at our series, and it's actually not performing as well as we thought. And there is a high failure rate for it. So for us, it's going to be a bit of a scratch, go back to the drawing board and maybe select our patients for it better. But it's going to get published either way. You know, people need to know what we've found, what works, what doesn't work, so they can learn. And, you know, we're in a center which we've got the volume to support that data.
So with that one in particular, I'm a little unclear as to what exactly are you studying? I mean, you have these patients that you thought they could just be a below knee amputee and, you know, whether or not they would walk as a below knee amputee or whether or not to go further, which is going to be inevitable if they don't get on
So
their.
yeah, so we're actually looking at people who are who have gone past the below knee amputation stage. So either they're not suitable for it, you know, there's too much tissue death, or they've had one and it's failed, but they still want to walk. And so we offer them a through the knee amputation, The prosthetics for that are
True.
much better. I mean, you get computers built into an artificial knee joint, and you don't have this horrible kind of hip belt that you get with a transfemoral and above knee amputation. You've got a nice end-bearing, lightweight prosthetic. If you want to cycle, you can get an app. You can change the microprocessor setting, increase the rotation rate, increase the bend. You can get on a bike and cycle, right? I mean, it's pretty neat now. So it's looking at those guys. It's looking at, do they walk? How far do they walk? Do they use walking aids? What's their quality of life? How much pain do they have? And what's the failure rate? How many of their wounds break down and don't heal? So, you know, I'd say at the moment, more wounds break down than we'd like. It's not as bad as some people have reported, but it's enough to make us be selective in who we might offer it to, in terms of we need to be upfront and say that, you know, 1 in 4, 1 in 5 people might come back for a further operation. You need to take that into account. For the ones who it works for, they got their life back. They walk down the street, you know, you know, it's a good life. It's a good game changer for them, and their pain levels are very small, which is really interesting. Much smaller than our below knee cohort, which is really interesting. I don't know why. So anyway, we're getting these messages, and for us, it's looking at our practice and publishing our practice so people can see what is going on and learn from it and compare theirs.
So there are different types of doctors that are out there with different philosophies. Was there a defining moment in your career where you became a doctor that is practicing medicine, helping to create the change, helping to generate the evidence, versus someone who is, and it's not knocking the other side, but it's just you have different types of doctors, different personalities, but you have another type of doctor that is purely by the guidelines, evidence-based. If there's no evidence, they're not going to do it. And it's all by the book. So you have those, but then you have the ones that are more practicing medicine and creating that evidence that could literally shift those guidelines going forward.
Well, I guess I'm both. So I sit on the European Guideline Writing Committee for Peripheral Arterial Disease. And what I notice is that by the time we've written the guidelines, like they're already out of date.
Yes.
And so we have a lot of
Yes.
research recommendations. So for me, and some of the stuff we don't even talk about, like, you know, looking at patients who are not operable or not operable. There's not even, I mean, what do we do with them? They're not even mentioned. They're not even mentioned in the guideline. So for me, understanding where the gaps are, and luckily we've got so much young talent coming through our unit. All of the guys get a project. I think Kenan is like project 3 or 4. He's been quite heavily involved in the last couple of months. Alfie's got the implantable antibiotics as his main project, and Shockwave as another project. So all of the guys pick up projects as they go through, and they need this kind of stuff to understand how to be reflective in their practice, understand what the benefits are. Kenan's working on a really interesting project at the moment, looking at life after deep vein thrombosis. I don't know if Kenan, you want to tell us a bit in a couple of lines about what that's all
Yeah.
about.
You need to unmute.
Can you hear me now?
We
Yeah.
can.
So we don't only look at arterial disease, we also look at venous disease as well, just to be a holistic vascular center as well.
Good.
So
Yeah.
we noticed after the ATTRACT trial, which is a very big randomized control trial in 2017, which found that actually directed catheter-based thrombolysis for deep vein thrombosis didn't really improve or wasn't significantly different than anticoagulation in terms of the deep vein thrombosis and the prognosis of these patients. So we started looking at other forms of treatment like compression stockings. And that's what we did in the center. Mr. Thapar led a randomized control trial, which was published in this year in 2025, and we've just completed the meta-analysis of randomized control trial just to guide the literature on the use of elastic compression stockings with the prevention of post-thrombotic syndrome, because there was a bit of a fiddle in the literature, a bit of back and forth with, is it significant? Does does elastic stockings prevent post-thrombotic syndrome? Does it not prevent? And for note, post-thrombotic syndrome is a very important syndrome that happens in patients after deep vein thrombosis, which can affect the quality of life massively, which includes swelling, pain, ulceration, even at sometimes. So just looking at that and how can we prevent that after deep vein thrombosis. And really the literature has been back and forth on this with a very big randomized trial back in 2014, just offsetting everyone, saying that there's no significant difference between stockings versus no stockings in post-thrombotic syndrome. Whereas now, after multiple trials and after the CHAPS trials that we did in our center, we're just doing a meta-analysis which found that actually stockings can prevent post-thrombotic syndrome in these patients. So it's quite a significant trial, and we're trying to contribute as much as we can, not only to the arterial community but to the venous community as well.
You just got to get the patients to wear them.
Exactly, and that's actually part of the secondary outcome of our studies, to see how the adherence for these stockings is, because it's always it's tricky as well. Yeah.
Good luck with that.
Yeah. So
it's not easy.
Yeah. So in CHAPS we had a lot of things. We had videos. We had text message reminders. We had lots of different ways of encouraging people to wear stockings, free fitting appointments, check-ins, Facebook groups, and our adherence was pretty much as good as you could get. But it is tough. It's just like exercise in PAD. It's a whole behavior change. It's managing your chronic condition. People always ask me, so you did CHAPS in the UK. What about if you did it in Australia, where it's like, the temperature is like tropical? Are people going to wear stockings? And I said,
we had that problem in Florida.
Yeah,
my
100%.
Patients are like, are you
100%.
kidding?
100%. And it's a natural criticism of the trial that it works in cold climates. And it's where randomized control trials sort of fall down, isn't it? That no one considers this other stuff, which is really obvious. But yeah, so
what do we do for those? We need another trial. We need to get our friend Dr. Shannon Thomas and Dr. Ramon Varco from Prince of Wales and Sydney to give us some options down under for the hot weather.
Exactly. Or we'll send Alfie down there.
Oh, good plan. Alfie, that can't be so bad going down to Sydney.
Yeah, I think I'll take up that research opportunity.
Something that worked for my dad, which is interesting, good timely discussion on that, was something like Vascular or a Venixa, an over-the-counter. So that really helped him. He was not a stocking wearer, could not handle it in the hot weather. So I don't know if any studies have been done on those, but seemed to help him a lot.
Yeah, there's lots of drug trials in venous disease, flavonoids and things like that. Actually, I think like where the community is going is the electrical stimulation of people's feet. Yeah, so we are part of Revitive. So it's an industry study looking at the Revitive device, which is an electrical stimulator. You put your feet on it, you have to have contact with the pads and use it for half an hour, ideally morning and evening. And we're looking at that for different indications. We're looking at it for venous, for diabetic neuropathy, even for early and moderate PAD. So I think just watch this space. It's an area where, for people who don't want to wear stockings or can't wear stockings, is this going to be a second line treatment?
That was interesting. My dad's vascular surgeon, when he had he was stuck in a chair after he fell and broke his hip. He made him get one of those and use it multiple times a day, which I thought was interesting. And he did great. But we get a lot of questions in our PAD group about these types of devices. I laugh because people don't want to walk, and they're always looking for new options that are going to improve their circulation without having to walk. And so there are all kinds of these types of things on that say that they improve circulation in general if you use them, and patients like, hey, what do you think? Can we use these? But they also have some contraindications, right? For people with heart failure, and also people in advanced stage PAD where their plaque may be unstable, is what I was told.
Yeah, I think if you have an implantable cardio defibrillator, Allegedly, if you have epilepsy, and if you have open wounds, and people with diabetes are always worried about any kind of like rubbing or contact, because they can promote ulcers. We had one guy in our trial who developed an ulcer. Luckily, it wasn't on the sole of his foot where the device was in contact. It was somewhere else. But he stopped using the device because he was worried, which is I guess is fair enough. But yeah, I don't think we got any evidence so far in arterial, and we're looking to see in like diabetic neuropathy, is it going to be of benefit? We know in venous it shifts fluid, but does it alter the disease? Does it control post-thrombotic syndrome? Don't know yet. Don't know.
I love that you guys are on the cutting edge, but you're also, it sounds as though you're really listening to patients and you're seeing what they're saying out there and the questions they're asking and the things that they're trying just out there on their own, so that you can create the evidence that can guide them more effectively with, the decisions that they're making outside of clinic. And especially having a device like Revitive that patients have access to, they're making the decision on their own to do it. And you're like, whoa, wait a minute. You know what? Let's actually study it. We're not just going to take the marketing claims at face value. We're going to do a real clinical trial. And that's what I love so much about your team and why you are the Global Luminary of the Year. And we applaud the entire team, for everything that you're doing, because we appreciate that you're not just resting on your laurels. And yes, you do create the guidelines, but you keep pushing forward, and you say, hey, you know what, let's keep creating new evidence. We haven't found a cure yet. And I think that's what's so encouraging, and it gives so many patients hope.
Thank you. Well, all of our research really is done in collaboration with charities for PAD, like the Limbless Association. A lot of our limb salvage trials, we said to them, we'd like you to be on board. And they said, no one's ever asked us to do a trial about limb salvage. We're the Limbless Association. I said, would you like to? They said, we'd love to. And so who else? I mean, they all of them know PAD inside out. So they were great patient experts, and they sit on our trial committees for Duster, which is a limb salvage trial. Another great example is some of the stuff that Kenan is doing with ruptured aneurysm. It's a bit different to legs, but we found that we didn't really have much support out there after ruptured aneurysm, which is a near fatal condition. Sometimes people.
Aorta. Are you talking abdominal or thoracic?
Both, yeah.
Both.
So, we have patients that have been dead who are alive, and we have patients who are alive who are dead, who have been dead, and their families left over. And this is something that, we feel personally, it's a very, very under-researched area, to the point where we don't even have an information leaflet in the National Health Service about ruptured aneurysm. We don't even have an information leaflet. So Kenan, I don't know how many jobs you've got, Kenan, but do you want to tell us a little bit about how you're developing the ruptured aneurysm support for families and for patients?
Sure, yeah. So with the ruptured aneurysms, as you know, it's quite a life-threatening disease and life-threatening condition, which requires immediate surgery. And quite often, the patients are rushed from either from our hospital or from other hospitals, because we're a tertiary center, to our hospital to have this surgery. And the relatives are left behind with basically being told to wait in the waiting rooms. And when the relatives are waiting in the waiting rooms while their loved ones is being operated on, while the loved one of them is being operated on, the relatives in the room, they're just looking around the room, just trying to find what's happened. They just try to find any information they could about what the condition is, how did it escalate up to here, etc., etc. And unfortunately, there hasn't been any information on that. So that's what we're trying to get some information leaflets, get some posters up in the relatives' rooms, just to educate the relatives of the patients about what an aneurysm is, what a ruptured aneurysm is, what is an aortic dissection, how can this impact the patient, why does it need immediate surgery, and all that stuff, with QR codes, with trying to have some visuals on the poster, just to let them know, to give them some reassurance on what is happening to the relative right now, why is it taking so long, etc., etc. So that's a very important thing as well that we're trying to manage for, and we're trying to get up for not only the patients but the relatives as well.
Interesting topic, because Joshua, our producer, is on the board for Think Aorta, and also is the producer for Aortic Hope, which is one of our sister charities here in the States. And that's something that they work on. And I'm sure he could help create some connections for you with patients and with their organizations to see how they can assist in this very valuable project, because it's personal to me. My mom passed from a dissection. Would love to know. I don't know the difference, if there's a difference between dissection and rupture. My mom went. They say that there's no symptoms. I can literally write up the entire, I can map out the entire timeline of symptoms that led up to this, that we should have caught it, should have caught it, should have caught it. Because then when we looked back, it was there. So, it's something that's very personal for me. Happy to be involved how I can. Would love to continue to know more, but I can connect you guys if it's helpful after this, so
Please
that
do. Please do.
we can support your efforts.
And Kim, it's personal for me as well. My father-in-law passed from a ruptured aneurysm, and not a lot has changed in the community support that happens afterwards. And so have a look at our Facebook page, Life After Ruptured Aortic Aneurysm. So we get all of our patients and their families to post on there afterwards when they go home. It's part of their kind of debrief, and they get a follow-up phone call from one of our specialist nurses at 2 weeks, and we ask them to write a debrief. And so the debrief gets edited and it gets posted anonymously on the Facebook group, and all of our other patients have access to this. It's not just the survivors. So sometimes we, as you have experienced, you remember every detail of what happened, and part of that process, the dealing with that, is writing it down and understanding and sharing it. And so that's what the Facebook group is there for. It's for an unmet need, really, in this community.
Yeah, it's awful. And then I come to find out that I have a thoracic aneurysm, just slightly dilated, but glad that I went and got checked and got this early. So definitely personal. I'm so sorry you went through that as well. It was devastating. We didn't know until we got the autopsy what's
That's
happening.
exactly
But
the same. That's exactly the
really,
same. Yeah, exactly. Autopsy report. And that's what it was in the old days. No CT scanners, just very, very, very difficult. And some of the things that come out of there are just absolutely heart-wrenching, Um, so, but I'll give you a couple of fantastic little bits of news. So on that
yeah.
topic, on Sunday, uh, my wife and I got invited to one of our Dead and Alive Club members. So this gentleman has been dead twice and is alive twice from 2 ruptures. The same guy, and he essentially had a rupture 4 years ago at our place. Got stented, re-ruptured about 6 months ago, survived that. Kenan looked after him on ICU, survived that, and it had his 80th birthday on Sunday, and he invited us round for a hog roast. So, I mean, it was...
It is just something. It's a
It's just
very, very nice
unbelievable.
journey.
It's absolutely unbelievable. And one of our thoracics, who has the same birthday as me, he had a coarctation of his aorta when he was a kid, had a patch. And Alfie knows this guy really well. He got stented as an emergency, a thoracic stent graft. He's now getting married. So we've got a wedding invitation.
This is the best. I hope you don't mind if I share this with our friends at Aortic Hope, that maybe they can put this up as an inspirational story on their YouTube channel as well, because that's incredible. And I'm sure that Joshua here is chomping at the bit to say, hey, Dr. Thapar and Kenan, can you guys please come on Aortic Hope and let us interview you too?
I think you would be better off interviewing these 2 guys, because
Yeah.
their stories are absolutely unbelievable. And
Okay. If you
the
can hook
fact,
it up for them, that would be great. They would love that. That would be amazing.
yeah,
They have such
absolutely.
a great community. And I'd like to do the same. I would love to figure out if there's a way that we can do what you're doing with your Facebook group, with our CLTI patients that are going through a lot of this. Maybe there's a way that we can create We already try to share their stories as much as possible. It's funny because there are other organizations that look at us and say, you're so procedure forward, you're all about procedures. And we're really not. It's just that we have a leg saver hotline. And I think people are kind of ignoring the people that are already in advanced stage and underestimating how many people are in advanced stage and focusing on these early stage where we agree. We have our walking program, we have a diet program that we officially launched today, that democratizes access for everyone who doesn't have access to a dietitian. We are all about patients being the partners in their care, but there's this very large and growing group of people that have this bottoms up disease, this newer PAD that we're looking at with diabetes and chronic kidney disease, a lot of below the knee disease, that it would be great to, do more in terms of facilitating the sharing of stories and the learnings along the way, which I imagine that you're doing with your group for aortic hope. I'm not aortic hope, but your Facebook group
Yeah, I
for
think it'd be
aortic.
great to do a page like that. I mean, I can remember, Kim, when I was a trainee going through the same center I work at, that we sometimes, like, a patient would turn up with a black toe, and the treatment strategy was wait till the foot demarcates and then chop it off. And fast forward 10 years, um, Alfie and I were doing a diabetic case, a gentleman who actually had a fractured, infected heel,
Yeah.
and with PAD, with diabetes. And I mean, if you look at the success rates for things like that, it's pretty low, okay? And historically, it's been really low. So I got a call from my orthopedic colleague who's in our multidisciplinary group, and he said, look, um, what's the vascularity like? Because I'm thinking about reconstructing this guy's heel tomorrow. And I said, tomorrow, okay, wow, that doesn't give me a lot of time. So we took the guy to up to the hybrid room, and we shot an angio and corrected his heel perfusion. The next day, he got his heel reconstructed and went home. And
Oh my
I just
goodness.
think in 10 years, we've come from a no reconstruction to like 2 procedures in 2 days and going home for, it's just unbelievable, the pace of change. And I would say that, there are two or three things which are really driving this. Okay, one are the procedures on offer, but two is building the team with the respect of the other players. Now, one of the amazing players that you won't meet today, probably because she's in bed, is Lindsay, who's our specialist vascular nurse. So she runs our team of Charlie's Angels, as we call them, for feet. So there's a group of very talented, mainly female vascular specialist nurses who run the hot CLTI clinic every day, and that's been totally transformational in the way that it cuts out weeks before diagnosis, weeks before they get imaging. They actually work where the imaging lab is for the vascular ultrasound. So people get a same day scan, same day decision, and that has been a really, really transformative
Yeah.
clinic for us. And we looked around the country, and there were places doing it like Leicester, and they'd had great outcomes. And we couldn't put a doctor in that clinic every day. So what did we do? We put a very highly experienced nurse specialist who trained all of her colleagues, and the doctor's room is right across the hall from her. So any problems, knock on the door. It
Wow.
works just great. So I would highly encourage people to think about things like that. That's been as big an impact in the care of our patients as any of the procedures. Yeah.
That's huge. And that's amazing. And I hope that people see this, and I'll separate it so that we can post it separately so that we can put it out there. It's a good lesson. We have these few questions that I ask everyone, so I don't want to keep you much longer. That is one of the questions, like what is a case or what is a situation that other physicians and clinicians could learn from? And that is definitely one that we can put out there as a great learning point, not only for people in the UK, but across the globe to do something like that. But I'm curious, describe a case where a patient should have been diagnosed with PAD sooner, but was not. And because of that, presented on deck for complex revascularization or amputation. And this particular series raises awareness of the delays in getting patients, the care they need because of stereotypical misdiagnosis, such as gout, arthritis, back issues, diabetes, diabetic neuropathy, when they should be getting a vascular evaluation and actually diagnosed with PAD.
So I've got a lovely guy who's 40. He's a musician, and he was a heavy smoker, and he had a small spot at the end of his big toe. It was really painful for him. So he went to see his family doctor. He said, "Look, I don't know what it is. Maybe you hit your toe. Come back in a couple of weeks." Didn't go away. Went to see a dermatologist. Took a biopsy of it, and it just got bigger and bigger and bigger. And so the guy came to see me, and he had something called Berger's disease. So he had like a smoking-induced loss of small vessels below the knee. And so Alfie's seen his angiograms, but he has nothing, no named vessel below the knee. It all runs on like small collateral vessels. But they're really good, those collaterals. They're really, really good. So I thought, I think there is some merit in carrying on here. So we used the new oxygen, topical oxygen therapy boot for him, and we gave that to him to go home, because the problem with not having these, he's got non-reconstructible vessels. It's getting the oxygen down there. So we gave him the oxygen boot, and we gave it to him for 6 weeks, and it took him about 8 to 10 weeks to fully heal that up. But he healed that up, and he's gone home. He walks around, he's given up cigarettes. He's got bad disease, but he's healed for now. And so that was a good example of just, the common thing that I see is, oh, my patient's too young. It's not going to be arterial disease. So like you, I've got 29-year-olds, both legs that I've revascularized, and it's unbelievable. I mean, especially if you've got type 1 diabetes with kidney disease, these are the kind of guys that suffer with this really difficult problem, or Berger's disease. It's another really difficult one. Yeah.
I just don't know how we're going to stop this. I mean, we have a Science Direct came out with a study and showing that we had a significant rise in the number of 18 to 27-year-olds presenting in the emergency rooms here in the United States with limb-threatening ischemia. And they say that a couple things driving it. One is the diabetes epidemic, insulin resistance, also the vaping trends that are going on, for the youngsters that are out there, and the increase in marijuana use for a lot of these people. So I don't know if you're seeing the same and are determining the same factors driving this disease earlier, but you can no longer say this is an old person's disease. You're too young to have this. Do the vascular evaluation.
Yeah, 100%. I just echo what you said. And marijuana, it's not safe. There's no filter. We've seen people with blocked aortas, age 40, very few treatment options. So it's not a safe thing for PAD at all.
Just a couple more really quick before you go. Share a story of a patient who actually impressed you with their effort to improve their PAD prognosis through their own perseverance.
I have a beautiful story. So we started the RESET trial and looking into the apps versus physio for claudication, so for early PAD. And so one of my first patients was a lovely sort of 70-year-old lady, very motivated, and she told me she was a teacher. And so she got randomized to remote physiotherapy. And so the physiotherapist rang me up a week later saying, "Do you know who you've just sent to me?" And I said, "I've got no idea." She goes, "So this lady used to be my physical education teacher." And the physio was now coaching her. Anyway, she did pretty good. As you can imagine, motivated woman, almost no risk factors apart from hypertension. And so Laura, who was our physio, who's the lead author on the RESET paper, that was one of the ladies she had to coach, and she really enjoyed it. And how the tables turn. You never know what's going to happen in life.
Now we have a lot of patients that are like, I've been moving. I don't understand. I don't have the risk factor. Like, why? It's counterintuitive that I have to walk. I just don't get it. I have been walking all my life. I walk now, I'm in pain, and you're telling me the answer is to walk more? So share your best motivational speech for walking is medicine.
Okay, so a little while ago, I trained for a marathon, and I didn't need to have my artery stented. I didn't need to have an arterial bypass to run the marathon. So what it did is it took a period of continuous training for about 3 months. And you know what? It really hurt at first. But really slowly, my muscles got better at extracting oxygen from the blood that coming down there. It's not that I was pumping more blood. It's not that I had more pipes. My muscles just changed. Something in them, the mitochondria, got better at extracting the oxygen from the blood. And so what we are doing for you is we are putting you on a mini marathon program, and it's going to hurt. And if it's not hurting, you're not going to walk further. So what I need you to do is actually engage with the app, engage with the 6-minute walk test, which is going to be your friend to see if you're getting better or worse. And if this works for you, you save yourself an operation, and 7 out of 10 people in our program will be saved from an operation. If you do need an operation and you're one of those 30%, you're in as good a shape as we can get you to have it.
That was perfect. I love it.
Yeah, I
Okay.
think Alfie knows that speech inside out.
No, because we had this guy that was on the other day that was he was explaining that we had a great question where a patient said, is, when you're sitting there and you're doing those reps, you're doing those bicep curls, and you get to that third set and you're a number 12, you have 15 that you need to get to, and your arm feels like it's going to be breaking off. I mean, the veins are bulging. I mean, is that how it works? Like you're building the same type of collateral vessel growth, and it's the same process by which when you take another step and you're pushing through that burning, you're pushing through that fatigue, that it's the same idea. I'm not phrasing it right, but that's kind of what he was saying. It was like, yeah. And that's kind of what you were saying.
Yeah, I think it's a combination of three things. I think it's a combination of, yes, you do grow some collaterals. I
Mhm.
think number two, I think your muscles just get better at extracting oxygen, right? So there are shifts which happen in the muscle themselves to help the hemoglobin transfer oxygen better. And the third thing is your pain threshold is changing, right? So you put all those three things together, I think that's what's happening.
Two more questions. This one, the most defining moment in your career, the one that we call the 6 minutes that matter, the catalyst for changing your career, whatever direction. What was that conversation you had or a moment that truly matters to you?
Wow. Okay, so I had two guys believe in me that have two or three guys that have really transitioned and made this journey work for me. One is Phil Puckridge in Flinders, where I did my fellowship, and I saw him take all the difficult cases on the ward and line them up for Friday and do 5 on a Friday, and most of them went home on Saturday morning. And I thought, I have never seen a guy like this. And he was such a cool guy and such a great trainer. And he won Best Trainer of the Year 5 years in a row. I mean, that speaks for itself, right? So I thought, wow, I have seen the top of the profession. I had a great guy when I did my research called Professor Alan Davies. I still work with him at Imperial College. Amazing brain, integrates everything in the clinic into research. There's not a patient which doesn't go through the clinic who's offered a trial for something. You only ever see that kind of activity in oncology, right? They're the only other people who have the organization and the thought process to put everyone into trials, and he did it in vascular. So you combine those two people, and I like a challenge, right? So I had a lovely lady who came in, and so I don't think she'd mind me telling you, her daughter was a famous singer. You probably of the generation where you will know her as well. So her granddaughter was Kate Bush, who's the singer. So she was 97, fabulous lady, used to come come in fantastically dressed, lipstick, looked great. Feet were absolute agony and just suffering terrible, terrible rest pain. And, you know, with a 97-year-old, you got to be a little bit careful. So I said to her, look, you know, you've got really bad peripheral arterial disease. And I took her to the meeting. I said, guys, what do you think? And do you know what came into my head? What would Phil do? And I thought, why don't I ask Phil? So I asked Phil. I've got a 97-year-old, very bad CLTI, both legs. What would you do? And he said, his reply was, can she lie flat for 1 hour? And I said, yes. He goes, do it. So I did one leg. She went home the same day, came back 6 weeks later. She goes, this leg is fixed. This leg is agony. So then I had to do the second thing on the other leg. She went home. I kept her overnight that time because we finished late. Went home the next day, and she came back to the clinic, and I got a nice message from her granddaughter about that. And you know what? All the perceptions you had about peripheral arterial disease just blew away with that case, because I thought, you know, she really was up for that. And wow, the technology has advanced to the point where we can actually deliver that. And for one of them, she went home on the same day. I mean, that was unreal. So I think that's just where we are. And it's not like that for everyone, but it was a lovely, lovely story, and, you know, it keeps me going. And I definitely have the record in our unit for the oldest patient.
But it just goes to show that you're focused on the quality of life for these patients, and you take that individualized approach, and that's what we appreciate you so much about you. And I'm so glad that you're training the next generation here. I have one last question for everybody. I would love for each of you to weigh in on this, because it's our fun one, that patients, it's not to mock patients at all, but patients want me to ask you this question. Just share a moment with a patient that still kind of has you shaking your head going, oh my God, I can't believe they just did this. I can't believe they just said that. But it's a learning experience for other people, because they may not be the only one. So think about it for a second. We've had doctors share that people used enemas in the wrong end when they were trying to do cleansing to lose weight. We've had dogs eating toes. We've run the gamut here. So, would love to hear your favorite stories. I can see the wheels turning over there, Alfie. Should we make Alfie go first?
I'm happy to start.
Terrible
Have you guys
thinking
got
for
one?
that sort of thing. But yeah, I'll let Mr. Thapar go first, and then I'll see if I can think of one in the next 30 seconds.
So I had a guy in clinic. He was coming in to reset, and he was a claudicant. And so I said to him, so just wanted to know, do you use tobacco? And he said, yeah, I smoke like about 80 a day. So I was doing the maths on this, and I said, what do you do for a living? He goes, I clean out petrol containers. And I said, how the heck do you manage to smoke 80 cigarettes a day in a job where you clean out petrol containers? And he goes, oh, the boss gives me like special breaks.
No.
So there you go. That was the most unreal moment for me. The boss gave him 80 special breaks a day.
That's a lot of breaks.
Yeah, that's also not a lot of work if you put the numbers together. So that's mine.
Smoking, sedentary. Oh my Lord. How about Kenan? Kenan, you got one?
I'm trying to think of one. The only one I can think of now is a patient that I saw in the critical care unit a couple of weeks ago, who was trying to defeat type 1 diabetes. So they're trying to defeat type 1 diabetes by not eating sugar, but eating fat. So they were thinking that, okay, if I eat a lot of fat, then this will take away my diabetes. And they ate a lot of fat, and they came out with an MI. So I'm just thinking, how did you get to this conclusion? And I said, I'm just in awe about that. That's the only thing I can think about. and he came up to our critical care. Fortunately, he went on and completed. He didn't have any further problems, but I mean, just thinking about it, he could have gone with this MI, with this heart attack.
Yeah, that's scary. But there are a lot of groups out there that have very different opinions on how to lower your A1C, and they don't think about the alternative issues that can be caused by certain directions. And so we always say, and that's why our new chief medical officer is a diabetes reversal doctor, and he meets with our patients every week and hopefully can keep them straight with evidence-based, safer methods. So that's a really important story to share. And Alfie, last but not least.
Well, I think the one that comes to mind probably after hearing Mr. Thapar's flammable story is another highly flammable patient that we had, who was a COPD patient who was on long-term oxygen therapy and was also using heavily paraffin-based moisturizing creams. And it was sort of remarkable that he'd managed to survive without sparking up in flames at any point. But I think that goes well with the petrol cleaner.
Yes. Well, thank you. It's always good to end on a little bit of a lighter note. We appreciate you so much. A huge congratulations to, your entire team for all you're doing to further PAD care. Again, not just resting on your laurels, but truly practicing medicine and helping to create the change that we all want to see, which is ultimately a cure for PAD down the road. So again, I'm so honored to present the 2025 Global Luminary of the Year Award to Dr. Ankur Thapar. We really appreciate you so much for everything that you do.
Thanks, Kym, and keep doing the good work your end as well. And it's a team effort.